So I have the distinct pleasure of introducing our speakers. Please come up. They will be speaking today about palliative care at Overlook Hospital. So a quick introduction. Dr. Abdul Mondul has been practicing medicine for 30 years. He worked with the New York City Health and Hospital System and has played multiple roles, clinical, academic, and leadership. His clinical experience has been centered in hospital medicine and palliative care. His leadership experience includes roles as patient safety officer, residency fellowship program director, and chief medical officer. He joined Atlantic Health System in 2014 as director of hospital medicine and palliative care at Chilton Medical Center, and in 2019 transitioned to Overlook Medical Center as director of palliative care service. Dr. Mondul is board certified in internal medicine, hospice, and palliative care. To his right, Sarah Galo works as chaplain with the Overlook Medical Center palliative care team and has previously worked in hospice. She is board certified through the Association of Professional Chaplains and is currently working toward her advanced certification in hospice and palliative care chaplaincy. She graduated with her Master's of Divinity from Drew Theological School in May 2020. And last but not least, Jessamyn Tabakin is a master's level advanced certified hospice and palliative social worker who works on the Overlook Medical Center palliative care team. She's a Rutgers University Aging and Health Fellow. Jessamyn is accredited in advanced care planning from the National Association of Social Workers. So I would love to welcome you.
Thank you very much for the introduction. Okay, good morning, everyone, and thank you for inviting us for this presentation here. First of all, I want to, thank all the veterans, that are here in the room. Thank you for all that you've done, for the country, actually. So it's a Veterans Day today. So what we wanted is to share a little bit of what palliative care is, what is the palliative care medicine approach at patient care, and go over some of those details. From our perspective and our objectives are really to go over some of the background in palliative care. Why is palliative care there? How it evolved? We want to describe, the principles of care and referral to palliative care, as well as review common interventions in palliative medicine and advanced care planning. We're going to have a special component at the end when talking about advanced care planning, the type of documents that could be completed, and the importance of those elements in healthcare. So we all know that navigating healthcare is very simple, yes? Very easy. But no, actually navigating healthcare is extremely complex. When you think about medicine, and we as doctors, when we're looking at codes, even for billing or codes of diagnosis, we look at a system called the ICD-10. You know how many diagnoses are there in the ICD-10? 74,000 options. That's how complex medical care is. That's only the diagnosis. Then we need to add up different components. One of them is the social factors of healthcare, the spiritual factors that affect healthcare. How about communication? So there's gaps in communication, gaps of communication with patients, gaps in communication with families. And actually, I heard once that the only way that you can get your primary care provider to talk to your neurologist and your cardiologist is to invite them for dinner. So communication is an issue. So then you need to throw up more issues like insurance, for example. Yeah, navigating insurance is very complex. So, in order to navigate this system, it's very important to create networks. And, a couple of networks that have been created and evolving, especially for patients with complex illnesses and advanced illnesses, are both palliative care and hospice medicine. So this is what we are. We are a network, and we're trying to take care of the patient in a holistic manner. So what is palliative care? And this is the definition really for Medicare and Medicaid services. They talk about an interdisciplinary care component. I tend to call it more as transdisciplinary, more than interdisciplinary. And the reason why I say that is because we work together. So we have our chaplains, we have our social workers, and we're really integrated. We don't work in silos. So that's why I think it's transdisciplinary. And we collaborate very closely with other caregivers and with other providers in the hospital, for example, with nursing, which they are at the bedside. So the aim of palliative care is to relieve suffering and improve the quality of life for patients with advanced illness. And one important component is the families. So it's very important to not only involve the patients, and sometimes, there's communication with the patient individually, but families are not involved. So that's a very important component here. The other piece about palliative care is that it's offered simultaneously with all appropriate medical treatments. So I think I get this question. Sometimes we go to the bedside or a patient is referred to my clinic. They come into palliative care and everyone thinks, oh, this is hospice. All right. So palliative care is not hospice. Palliative care can be provided simultaneously with other appropriate interventions. And we're going to talk a little bit about that. Hospice is a part of palliative care, but it's not all palliative care. Palliative care, ideally, patients should be referred earlier in the course of a difficult illness or advanced illness. What does it mean? It's really patient and family-centered care, and it's important to navigate and to support patients and families throughout the continuum of the illness, addressing physical components, addressing the social components, addressing the spiritual needs, and always respecting the autonomy of the patients. So palliative care is not there to tell you what to do. That's not what we are there for. We're there for to try to put together all the elements that are necessary to have informed decisions. This is what it is. At the end, it's really patients and family deciding, but they need to decide based on good information, appropriate and accurate information. So there's been a conceptual shift on the way that we deliver care. If you look at this graph here, this is how traditionally we've been delivering care. Well, it in the past, it was providing life-prolonging care. And then at some point of time, well, probably there's not much more curative treatment I can offer you. Go to hospice. And that used to be kind of like the model. I think the conceptual shift right now is to have palliative care, something in between those two elements. So have palliative care starting earlier in the course of illness and escalate palliative care along the way while life-prolonging care is de-escalated over time. And then there's a point of time in which hospice is appropriate. Hospice is appropriate, right. Now, the other component, in this conceptual shift is really bereavement support. And bereavement support is really important and is one element of palliative care and an element of hospice care. Okay. So how does palliative care differ from hospice? And I mentioned a little bit of these components. So palliative care is appropriate at any point in a serious illness. It is provided at the same time as life-prolonging treatments. I follow up patients. I have patients that I followed up for years in the clinic. They've had cancer. They have an advanced cancer. There's survival. Sometimes they're in remission. And I'm there to provide symptom management and support. So there's no need to choose between treatment approaches. So patients could be having chemotherapy, having other interventions, and they can follow palliative care. Hospice is a form of palliative care. And again, it provides care for those patients in the last few months or last few weeks of life. When it comes to hospice, it's something that was developed by Medicare to provide additional support for patients with advanced illnesses. So it provides additional components of care at home because hospice, the best place to provide hospice is really at home. When patients are referred to hospice, this must be certified by 2 physicians. And the certification has to say, this patient is probably prognosis less than 6 months. I've had patients in hospice for a lot more than 6 months, by the way, and it could be recertified if the diagnosis is still appropriate. Now, the one thing about hospice is hospice does not include that active treatment or curative treatment. So if you're in hospice, you're not getting the chemotherapy because there's no more role for chemotherapy, for example, or those kind of aggressive interventions. So this is how I see how palliative care interacts with all these components. So palliative care interacts with life-prolonging therapy. It interacts with hospice as well, and symptom management. So we do a lot of symptom management, especially pain, but there are other components of symptoms, shortness of breath, lack of appetite, etc., that we address through palliative care. We do those assessments when we're seeing our patients. So why palliative care? And I think it's important to go over what's the background, why this network was started, and why we try to do this work. So there are different elements here, the changing demographics and life expectancy in the United States. We're going to discuss a little bit about what has been the family satisfaction with hospitals as the last place of care. There's been some education gaps for healthcare providers when it comes to end-of-life care, symptom management at the end of life, etc. And what had been identified as inadequate symptoms and pain management at the end of life. So let's talk a little bit about demographics. This is global life expectancy over the course of humanity, probably. This starts many, many years back. So if you see, global life expectancy had been very, very flat. So yes, for many, many years. If you see this trend, it's like 25 years old all along until the 1800s. And do you know what actually made the biggest difference in life expectancy at that time? Vaccines, public. Okay, so the one element that actually had the biggest impact was separating sewage water from clean water. So sanitation, that was number one. At the same time, vaccines and antibiotics at that time. That's when we had this really steep increase in global life expectancy. Now, there's been some other elements in healthcare. You talk about chemotherapy, you talk about some other advanced interventions right now, but those have not really affected as much as those elements that happened during the 1700s, 1800s. So this is the global life expectancy. Let's talk a little bit more about that. The United States, the median age of death is 78 years old. By the way, women actually have a longer life expectancy than men, 5 years or so. That gap is closing in the most recent years. If you survive to age 65, median age at death is 82. If you survive to age 80, the median age at death is 88. Currently, and this is information from the CDC, and currently in 2023, there are 6.1 million adults in the United States that are older than 85 years old. This is 2023. And the expectation, and it is projected that this is going to increase to 13 million adults older than 85 years old by year 2040, right? So it's going to double up. And this is important, and it's important for healthcare because we need to take care of adults and old patients really in the country. And what happens is that, when you get older, you would like to be happy and enjoying your life. Yes. Playing bridge, for example, or having fun at home, having a lot of fun at home. On the other hand, we know that as we grow old, we develop disease, and disease comes with a lot of symptoms. Disease comes with spiritual components and suffering, psychological components and suffering. And these are things that we want to address from having these support services. So what do patients with serious illness want? So this was a study that was done. It's interesting. They really ask patients with serious illnesses, what do you want? This study was done on patients with end-stage renal disease. These are patients requiring dialysis, patients with HIV/AIDS, and patients living in long-term care facilities. So what do patients want? So they want pain and symptom control. They don't want to suffer pain. They don't want to go through a lot of symptoms. They want those symptoms to be controlled. They want to be comfortable. Um, they want to avoid inappropriate prolongation of the dying process. So that is also very important. And sometimes what happens is with some certain interventions, we're not prolonging life. Sometimes we're prolonging death. And this is one thing that is very important. And again, this is all very individualized. This isn't about what my perception and my perception of quality of life is for anyone. It's patients' own perception and what they want at the end of life. Patients with serious illness, they want to achieve a sense of control. They want to relieve burdens on family. I hear this every day when we're sitting with families and with patients. Patients don't want to be a burden. And it's important really to provide that psychosocial, that spiritual support, the medical information that they need to understand they're not a burden on their families and what services and what support can be provided for patients. They want to strengthen relationship with their loved ones. So it's very important. So it's important to guide as best as possible, close the loops on any open items during life or relationships and with patients are suffering serious illnesses. This slide, I'm not going to go in extreme detail here, but sometimes what happens, and we know that it's important to discuss goals of care, to discuss advanced care planning, but this really needs to be done in a timely manner. Yes. What happens occasionally is that these conversations don't occur until there is a crisis. So there's a crisis, a patient hits the emergency room, they're in intensive care. Oh, we need to discuss about what are your wishes, what do you expect, what are your expectations, how much aggressive treatment do you want? But that's probably too late. So this study actually looked at patients with advanced cancer and what was the impact of having goals of care conversation earlier in the course of the disease. So if you see, and this was a very interesting study, and patients that had end-of-life conversations timely, they actually had less ICU admissions in the last week of life, less use of ventilators at the end of life in the last week, less resuscitation, no, CPR, etc., no chemotherapy in the last week of life, no feeding tubes insertions in the end of life, and patients that had advanced care planning conversations actually were referred more commonly to hospice, and they actually were in hospice for more than 1 week. So if you have these conversations earlier, and what they look is patients that had these conversations earlier than 30 days before their death. All right. And I think it's important to have them even much earlier than this. But this was a very telling article. And it's important to discuss these things because I know that, and we respect patients' wishes and patients' decisions. Some people may not mind dying this way, but I know a lot of patients don't want to die this way, connected to machines with excessive interventions, which are really actually not prolonging life, but prolonging death. And a lot of patients actually would prefer to be like this. You're at the end of life, surrounded by your loved ones, being comfortable, have the symptoms controlled, that's the fear a lot of times. I want my symptoms to be controlled and die in peace. This is a study on showing us like what family caregivers want. So they look into families and they interviewed families, almost 500 families after 1 or 2 years of bereavement. And what do families want? They want their loved ones' wishes to be honored. So this is important. So to honor these wishes, we need to discuss those wishes. They want to be included in decision process. Obviously, it requires the patient permission, but again, we need to roll in the family. We always have meetings and we always try to gather the close family members that the patient want to be involved, so it's easier to guide decisions. They wanted support and assistance at home, some practical help, personal care needs, bathing, feeding, toileting. They want honest information, and that's very important. And that's one of the things that we do every day, trying to put everything together, trying to bring in all the information that comes from different providers, different specialists, and put together that with the psychosocial and spiritual needs for the patients. They want to have 24/7 access for questions and support, to be listened to, privacy, and to be remembered and contacted after the death of their family member. And again, bereavement is a big part of what we do in palliative care, following the patients at least up to 1 year, families after the death. Likewise, hospice does the same. What is the family satisfaction with hospital as the last place of care? This is patients that die in the hospitals. So what do family thinks about that last stay in the hospital? So a lot of patients, when this survey was done, they felt like there was not enough contact with the doctors, 78%. Not enough emotional support, 51%. Not enough information about what to expect with the dying process. This is important. And from our perspective, it's important to describe what you're going to be seeing. How does dying look like? And when families are prepared, it's much easier, to be there at the bedside, with their dying relatives. Not enough emotional support, 38%. And then not enough help with symptom management. So they mentioned in this study mainly pain and shortness of breath. So 19% felt like there was not enough support on that end. I mentioned about education gaps in healthcare. So traditionally, there's been some deficiency in pain and symptom management education. When it comes to this element of healthcare, there's really no structured mandatory training in end of life care during residency. So a lot of times doctors end up having these discussions after they graduate, and then they start practicing and they start seeing their patients and having those conversations. There's no hospice rotation during residency. A lot of these have changed really over the last years. There's more effort in including some of these elements in curriculums in medical schools and residencies. But still, again, a lot of this learning ends up happening once nurses are graduated and coming to the hospitals, doctors are graduated and coming to the hospitals to work. Now let's talk about symptoms. And this study that I'm showing here is it's an old study. It's 1995. Robert Wood Johnson Foundation funded this study, but this is the study actually from where palliative care actually started and was brought to the eyes of everyone. So they look at 9,000 patients with life-threatening illnesses. 50% of those patients died within 6 months of entry to this study. There are 5 big tertiary centers in New Jersey, actually, and other states participating. And when they look at the symptoms, they figure out that half of the patients that died actually had moderate to severe pain during the last 3 days of life. So pain has not been very well addressed at that time. And 38% of those who died spent more than 10 days in the intensive care unit in coma or on a ventilator. And again, there may be some patients that they're okay with that, but I think the majority of patients, people with advanced illnesses, don't really want to go through those interventions at their end of the life. Symptom control. This is a study on pain among hospitalized patients with serious illnesses. This is 5,000 patients. This is just to illustrate that pain is not only present in patients with cancer. So you see patients, 60% of patients with colon cancer have pain, but there's also other diagnoses that patients can suffer from pain, like liver failure, like infections, severe infections and sepsis, COPD, heart failure. So pain is a component on multiple diagnoses, and it's important to address those. A lot of times, physicians that are taking care of patients, they're taking care of the medication for the heart failure, medication for the COPD, the bronchodilators, but they're not addressing some other components, depression, lack of appetite, pain again. So it's important from our end to support that decision-making with the teams. This graph actually also reflects on how common symptoms are in patients with advanced illnesses. So you have different diagnoses here, like cancer, congestive heart failure, COPD, chronic kidney disease, patients with dementia, and patients with AIDS. And you see that there's multiple symptoms that patients actually describe: shortness of breath, fatigue, lack of appetite, nausea and vomiting, constipation, anxiety. So when we assess patients from palliative care perspective, we address symptoms, we have screening tools, and we address every symptom based on the physiology and what could work best to take care of all those symptoms. So symptom control, a very important component of palliative care. So it's time to call palliative care consult, so this is a practitioner says, there is no easy way I can tell you this, so I'm sending you to someone that can. So, and this is just a segue to show you the triggers that we use for referral for palliative care. I'm not going to go in extensive detail, but at least we want patients that come with this diagnosis to be referred to palliative care team to try to have that holistic approach. Patients with stage 4 cancer, COPD on home oxygen, heart failure, especially if their functional capacity is not good, dementia, other neurological advanced disorders, ALS, etc., cirrhosis, and end-stage renal disease, especially if the patients have required multiple hospitalizations or ED visits. Patients that are having symptoms that are difficult to control due to serious medical illness, things like pain or shortness of breath, or patients with psychological or spiritual distress. So we have a pretty well-established palliative care program at Overlook. And, many times, and providers know what we do. So many times they're calling us, not for me to go there as a doctor, even though we go there as a team, but for Jessamyn to address psychosocial issues or for Sarah to address spiritual issues. So a lot of times we get a referral, please evaluate for spiritual support through palliative care or psychosocial support through palliative care. It's important for us to discuss goals of care and advanced directives and patients that are dependent on certain technologies, patients that are on hemodialysis, they're on home oxygen, artificial nutrition, or they're bed-bound or wheelchair-bound. So these are the triggers that we use. So now I'm handing this off to Sarah.
Thank you, Dr. Mondul, for getting us started. Again, I'm Sarah. I'm the chaplain with the palliative team, and I'm going to be taking us into talking about the transition to comfort measures, as well as looking into what hospice is. And just so you're aware, I started after my residency, I did 2 years of hospice work in the community. So often we are asked, to come in for consultations, as Dr. Mondul said. And sometimes as, the trajectory of illness goes on, as life prolonging care is de-escalated and palliative care is escalated, just want to make sure we often begin the transition to comfort care, which often takes the form of hospice, which is an insurance benefit and truly grew out of the hospice movement in England, then the United Kingdom with Dame Cicely Saunders in the 1950s. And just so you're aware, comfort care is something that can begin within the hospital setting. That doesn't necessarily mean automatic hospice enrollment, as it is an insurance benefit. There are consents that need to be signed, discussions that need to be had with the family. Hospice care typically takes place outside of the hospital in a variety of settings. Whether it's someone's home, the home of their loved one, if say home isn't their own personal domicile, isn't the ideal setting anymore, a long-term care facility or nursing home, or a place, a residential hospice such as Center for Hope, which is in Scotch Plains. And hospice is really really shifting the goals to focusing only on comfort. And what does that mean? That means respecting dignity, focusing on compassion and support at end of life, and meeting those managing symptoms that can be troubling. And that's not even just, the potential shortness of breath or pain, but dealing with, the emotional and spiritual components that can arise for patients and their families at end of life. And I think is especially important is that shift in seeing the patient and the family as a unit of care. We're not only attending to what is happening with the patient who, maybe, especially sometimes patients aren't always able to communicate with us directly, verbally, as they near the end of life. However, then we can address the patient's needs by also speaking with the family. And that's often where I sometimes come in with addressing the spiritual and psychological needs at end of life, psychosocial needs. Hospice is, excuse me, as I said, a benefit that is, it's an insurance benefit, is covered under Medicare Part A and most insurances. An important component of hospice as well is that interdisciplinary or even transdisciplinary support. I certainly do not take the place of a medical provider, but part of our training too is when we're visiting with patients, whether palliative or when I was in the field for hospice, is being able to assess for pain. And even it can just be as simple as, are you having pain today? Could you tell me on a scale of 1 to 10? And then, I taking that on to communicate to the medical provider to make sure, that pain or that symptom is being addressed. Um, Part of the interdisciplinary model is also including bereavement support, which is something that is offered for 13 months following the death of a patient. But often too, bereavement needs sometimes go beyond that 1 year. And at that point, it's really important to refer to community resources. Common diagnoses that make someone eligible for hospice. Cancer, such as when there is no longer oncological treatment being offered, usually in a later stage when there may be metastases, so it is spread from its primary site of origin. And end stage heart disease, end stage liver disease, such as like thinking of congestive heart failure, or COPD, end stage renal disease, end stage liver disease, stroke, or someone being in a coma in a more permanent persistent vegetative state, HIV, AIDS, as well as neurological diseases in more advanced stages such as Parkinson's or Alzheimer's or ALS. This is taken from a study just showing the benefits of palliative care and trying to get us involved earlier. It's actually appropriately for Veterans Day. This is taken from a study done with the VA, and following how family survivors perceived the benefit of palliative care versus usual care, specifically in an inpatient setting. Palliative care was found to be superior when relating to emotional and spiritual support, information and communication, care at the time of death, access to services in the community, ensuring a patient's well-being and dignity, care and setting that are concordant with patient preference, addressing pain. And I think especially most relevant for in terms of veterans, addressing symptoms of post-traumatic stress disorder. I think what all of this highlights as well is that interdisciplinary model. I'm going to keep saying that because that's how we work best, I think, that it's not just it's not just on one medical provider, such as Dr. Mondul, to come and address everything. We're working together as a team to make sure that the person's whole pain, not just what's going on physically, but what is going on emotionally, spiritually, psychosocially, is being addressed. I think I do see a hand raised, but I think we'll be doing questions after. Um, And two, I think to kind of just highlight as well the information and communication, as Dr. Mondul said, there was that study done that showed, families not being satisfied with the amount of contact that they had with a medical provider. And because we're a consulting service, we have more have a little more time to be able to sit down, or it's someone like myself or Jessamyn coming in first and getting that story. What brings the person into the hospital? What makes that person unique? What is their understanding of their illness? And then being able to relay that information to the doctor or the nurse practitioner and bring them back in, I think really does enhance the communication and the transmission of information. Oh. And what does it all mean from the patient perspective? For patients, palliative care is key to relieving symptom distress and navigating a complex and confusing medical system. It's also help understanding the plan of care. Sometimes I'm sure, just speaking for myself, being in a primary care office, sometimes, those visit times seem to get shorter and shorter. And sometimes there's so much going on that you can't quite retain it. Even when you can go now and look at your documentation and see the records, there's not always that time to fully absorb and ask questions. But with the service of palliative care, we're able to come in and do that ongoing communication in the inpatient setting, as well as at times for outpatient when some patients are referred to Dr. Mondul's clinic. This is also, it's allowing for the coordination and control of care options and allowing for simultaneous palliation of suffering along with continued treatment. So again, there's not, some patients or families may, I'm thinking of oxygen requirements. Someone, requires a nasal cannula, portable oxygen at home. Sometimes there's a concern that, oh, is going with palliative or going with hospice, is that going to take away my oxygen? And I can say absolutely not, because that is an important part of addressing symptoms and addressing comfort. And finally, it's, practical and emotional support for exhausted family caregivers. And one thing I want to also raise up for this is, especially, we're very blessed at Overlook to have a caregivers center. There aren't that many. I think there are under 15 nationwide, but it's a specific place in the hospital that's for respite for family members. If, there's a lot going on, it's a little retreat in the midst of the busyness of the hospital. And not always able to offer that for everyone at different places, but in terms of the palliative support and our team model, we're also able to address those needs during our visits. And now I am going to turn it over to Jessamyn for the final part of our presentation.
Thanks, Sarah. Good morning. Thank you for having our team here. As you can see, we really enjoy presenting. We're not invited very often to talk about death and dying and getting older. So thank you. The good news is that we are living longer. The bad news is that unfortunately death is not optional. One of my favorite philosophers, Soren Kierkegaard, life can only be understood backwards, but must be lived forwards. And I do think that many of us, having watched our loved ones and our fellow friends and family members pass on, there seems to be a lot of this hidden information that only you can gather once walking the path. I think palliative care is really important in being utilized as a tool, as we have walked that path many, many times with many, many patients and their families, and are a resource for incredibly important information to help you walk that path, whether your own or that of someone you love. Advanced care, in an interest of time, I'm going to go very quickly, because I think for advanced directives, living wills, most of this is going to be based in your questions specifically. Actually, how many people in this room have an advanced directive or living will? Well done. How many of you know what it says? Not bad. Okay. So having a living will is an incredibly important tool. Many of you in this room have utilized that. I think from our standpoint, one of the most important things to know is who is your healthcare proxy? Who is the person that you would trust to make decisions on your behalf when you are no longer able to make decisions for yourself? And a healthcare proxy may not be your spouse. In fact, you may want to make sure it's not your spouse. You may want to make sure that it's someone who understands the medical environment, the language. It's a foreign country. And so someone who knows you, knows your preferences, knows your wishes, and is able to make decisions on your behalf, not so much from an emotional standpoint, from more of a really solid understanding of what we can do and what we can't do at end of life. A healthcare proxy, very important. Durable power of attorney for healthcare, also very important. But in our sort of in and out day, advanced directives, living wills, they are your wishes, but they are not so actionable in the environment of a hospital. Things are happening very quickly, and we want to make sure that we have a clear understanding of what your preferences are, and we're not reading through your living will. But it's a good thing for you to bring in for us to have on file. 5 Wishes is something I like to mention. It is a resource, and we brought a ton of resources, and after the presentation and after questions, we'll be placing those resources out for you to have to continue these conversations. 5 Wishes is something you don't have to do with a lawyer. You don't have to sit down. You can sit with your family. It can be witnessed or notarized, and that can also serve as an advance directive. The post form is something that we use very often. It is very actionable. And it is something that I think is going to be important. How do I advance? I'm sorry. And it's going to be something I think will be important to go through, as we don't have to wait for you to lose your capacity to make your own decisions. You can participate in a post completion of physician's orders for life-sustaining treatments now. Great. So this is the post form. It's bright green. Sorry, I didn't bring in a bright green form. But this is something that we utilize very often. And this is a conversation that we're having with our patients very often. You do not have to necessarily be at end of life to have a post form. This is something that needs to be filled out between you, a physician or a nurse practitioner. As a social worker, as a chaplain, we're more than happy to talk to you about the post form, but we cannot sign that post form. It is a medical order. Parts of the post that I find the most important is we start with goals of care. So really creating a framework based on, if you are at end of life, and you will be, how do you want that to look? What are your goals? It could be, I don't want to be in pain. It could be, I want to be home with my dog. I want to watch Turner Classics movies. I want to eat by mouth, my whatever I want. I want a martini every evening at dinner. And I want to, I don't want to be in the hospital. I don't want to be poked and prodded. It could be a myriad of things, but this is a really good way to start to think about what it is that you want at end of life. And the martini is important, always. And then things that are also addressed in the post form, which we don't tend to think about, are things like artificial nutrition. This is an issue that comes up for our patients and families very often. And this is something that is also addressed on the post form. And there is, yes, I want it, no, I don't want it, and the middle path, which is sort of like, if it's being provided temporarily, perhaps I might think of it as a bridge, but I don't want a feeding tube for the rest of my life. And then we talk about things like resuscitation. We talk about things like ventilators, but these are complex conversations. They are not black and white. There are many, many components to a person's care that can affect all of these interventions. So that's where your healthcare proxy comes in handy, because they're getting the real-time communication. You're communicating with that, they're communicating with that team, they're getting recommendations, and then they say, what would Joe want? You know, Joe would want this in this circumstance. So a lot of people say, I want to not be on a ventilator. I don't want to be on a machine, but I want you to give me a couple thumps if my heart stops, just, you know, to see if you can get me back. And so much of our education is really about how that is not necessarily possible. And that if you are pulseless and you are no longer alive, there is no longer oxygen going to your brain, you have, for all stated purposes, passed. For us to come into the room and resuscitate you, and that's what the DNR is, it's this, that, you know, we are pulling you back from a natural death. And that's fine if that's what you want, but you are going on a ventilator because you are not breathing on your own. So having conversations like this is not comfortable, but we have to start to understand the complexities of the technology that our medical system has offered to us, which are wonderful. But when you are at end of life, what is it that you want? And what we don't want to do is put you in a situation where you are not comfortable and not leaving the hospital, if that's not what you want. We have more hospitals in New Jersey than anywhere else. We have more end-of-life interventions, more aggressive interventions at end of life than any other state in the country, because we have so many hospitals. So it is extremely important for us to make sure that we have documented and thought about what we want and don't want. You can do this with your primary care physician. You can do this if you have a bunch of chronic conditions or if you get a big diagnosis. But you can start having these conversations with your spouses, your friends, your families, your children, your clergy now. Surrogate information goes at the bottom. That is a wonderful thing to have. Again, going back to the importance of a healthcare proxy, but it is not necessarily going to be the person making your decisions if you haven't already designated your healthcare power of attorney. So all very complex. Life is pleasant. Death is peaceful. We see it every day. The body does know how to die, and we tend to get in the way of that dying process with our medical technologies, which are both a miracle and in some cases can be a curse. So it's the transition that's troublesome. Death is not an event, it is a process. And with that, I thank you all so much.
I am now a big fan of palliative care. And I'm looking forward to hearing more from the questions that we have for our speakers.
Thank you all. It was an excellent presentation. A couple issues I don't think were really discussed. My mom was in hospice care in 2020 in her apartment up at Lantern Hill. She had home care aides, not medical at all, 24/7. My understanding, or what we discovered, was that's not covered by Medicare, but her long-term care policy helped, with the expenses on that. So you comment maybe on that. And secondly, in terms of medications, the home care aides could not give any medication. So we had to have a family member either, with her in the apartment or nearby. And also they had to be, we had several family members who were trained to give medication. So it's just a couple issues I don't think were really talked about. So maybe you can comment on that. Yeah.
So yes, I think sometimes when it comes to hospice, families have the perception that the benefit would cover someone to be with the patients 24/7 at home, and it's not like that. Hospice at home has nurses coming to assess the patient as frequent as necessary. They will come once, twice, 3 times every day if it's necessary to assess a symptom that is in control, and in communication with the physician that is in charge of the hospice patient or the medical director make those changes in medications. They do not stay with the patient 24/7. So for a patient to be in home hospice, they do require to have, a family member, a friend, or someone that is there with the patients 24/7. The benefit covers an hour or 2 hours of home health aid, not 24 hours. And that's basically what the insurance covers. It covers all the equipment that is necessary, hospital bed, lifts, commode, etc., that cover the equipment along the way, oxygen if it's necessary. It covers the medications. Now, if you hire home health aides to be there with the patient, home health aides are not really from their agencies, are not allowed to give medication to the patients. So yeah, that's true. And that happens, unfortunately. But again, when it comes to home hospice, the principle and what the Medicare benefit covers and the insurance benefit covers doesn't really cover like a nurse to be there with the patient 24/7. So, there ends up being an out-of-pocket expense there. There are residential hospices. I think Sarah mentioned Center for Hope, and that is expensive. So it happens to some extent, just like long-term care. And again, I think a lot of patients and families, they ask us, they think that Medicare is going to cover for long-term care when you go to a nursing home to live. It is not covered. So those are some gaps in healthcare and coverage from insurance, but we share the frustration on some of those elements. But I just wanted to go over what hospice actually covers at home. When just one last piece. So if a patient is in long-term care, that long-term care becomes the patient's home. So long-term care facilities, they do have contracts with hospices. So if the patients are transitioned to hospice, they can call a hospice that comes and visits with all that I mentioned in the long-term care with the same benefits, and that is covered by the insurance benefit.
We'll take a question online. Bill Tittle, can you unmute and ask your question?
Got it. Yeah, so my question is, do you ever facilitate support groups of patients during palliative care? What I've observed is I've had some serious illnesses, and frankly, a lot of my friends, they're just not comfortable with it. They can't deal with it. They don't want to deal with it. But if I were, let's say, in palliative care, I would love to be able to share my experience with others going through the same thing.
So I'm going to let Jessamyn answer regarding support groups.
Fellowship is incredibly important. I agree. And I think there's nothing more isolating than an illness. I would suggest, and what I suggest to many patients and their families, is to look at the specific disease, to look for support groups, whether through the Cancer Network, or if it's for pulmonary issues, or if it's ALS or heart disease, that there are very really bulky supports available through those designated services for support. We as a palliative care team provide support groups for bereavement. And I think this is also a really important community, because we also, are not gonna get out without losing someone. So talking through in bereavement support groups can be very helpful too, in again, establishing that fellowship in that community through illness and end of life.
Two questions. My wife's elderly mother is in the hospital, and she's going to stay there. And she's very demanding and critical of my wife. I'm just wondering how she should deal with that. And my second question is, there's a big spread, high to low, for the skill level of doctors. And one example is a dentist who did 2 jobs in 45 minutes that other diplomats said could not be done. So I know that there are star performers. Who's a star performer for lower back pain?
So I think the first part of the question was trying to deal with complex family relationships, which we are available, and that's part of the reason that sometimes we are called. I just got a text from a new consult that came to the hospital right now from the neurocritical intensive care unit, and it's mostly to try to address that psychosocial and complex relationships components. I think the other question is about back pain specialist. I think the elements for take care of back pain include a comprehensive assessment, and it could be done through a pain management team. It could be started by a primary care provider. I think the steps have to do with address any physical components of the back pain, having some imaging done, and figure out if there's any intervention that could be done. So, and there's different interventions. The intervention is not limited to medications or opioids for pain or muscle relaxants. Even though that could be the situation, we do have invasive pain management at Overlook. Dr. Sanyalar, actually, she does a lot of it. There are certain interventions that could be done, local injections, something called kyphoplasty to open the space in the disc if that's the issue with the back pain. It could go all the way up to surgery, but I think we need to do an initial assessment and figure out what is the reason for the pain to then figure out which are the potential interventions with, again, go from something very conservative as anti-inflammatory medication to something very aggressive like a surgery. If you're thinking about a surgery for back pain, the other component is really balancing the risk and the benefits of a procedure, and the comorbidities and potential risks for that.
Thank you for a really good presentation. I have 2 short questions. I think they're short. One is, you've mentioned bereavement support, but I don't really know what that consists of. What I'm wondering is it something that has expenses that get covered? And if so, how? And if not, does it mainly consist of support groups? So that's one question. And the other question is, New Jersey has a law about assisted death. And I wonder if you could comment on how your group in Overlook has a relationship to that law. What happens with that? Thank you.
Great questions. So I didn't include MAID because the presentation was running long, but so Sarah will answer the bereavement component because both Sarah and Jessamyn actually lead our bereavement support process. So MAID. So what you mentioned about this New Jersey law is called Medical Aid in Dying, and this has been going on for a few years. It's been approved in New Jersey and 12 other states in the country. Medical aid in dying, it's a law, and it provides the right for patients to take a medication that is going to end their life. You know, it's called medical aid in dying. There are different components for medical aid in dying. Number one component is obviously, you know, the patient, that's the patient's wishes. You know, they wish to have that medication handy to take it when they feel they want to take that medication, which is a combination of medications. Number two, the patients need to qualify for medical aid in dying. That qualification takes place by a provider who does the referral, you know. So patient Joe has advanced lung cancer, and the prognosis of life is less than 6 months. So it's almost like the qualifying for hospice. If you qualify for hospice, you probably qualify for medical aid in dying. It does require 2 providers. In New Jersey, the first provider actually does the referral. and the prognostication. And then a second physician needs to validate that information, confirm that prognostication. And that second provider is usually the prescriber, the person that prescribes the medication. The other piece that you need to know is like, even when patients get a hold on the medication, not everyone takes the medication, by the way. And I can give you some statistics. So with Atlantic, we actually, we did a lot of work when the law was published, and we have a great process and a great system to support patients that pursue medical aid in dying. So, and I can tell you, it's the only medical health system in New Jersey that has something like that, or to support medical aid in dying. We have a navigating program. It all goes, her name is Yvette Vieira. She's incorporated. She's part of the palliative care and bioethics for the corporation. So they navigate the patients, and all the patients that are pursuing MAID, we also promote them to be under home hospice. Patients that decide to pursue the MAID route also, they need to be able to take the medication on their own. So that's part of the law. It's not like you can put it through a feeding tube or things on that way. That's from the regulation here in the state. It actually reads something like the patient should probably be able even to pick up the medication. That we don't expect that, but they need to be able to take it on their own. This medication is taken in an empty stomach. It takes probably 15 minutes in general for the patient to pass away after they take the medication. From our statistics, and Yvette has been running stats probably for 5 years now or so since the rule went on, and only 30% of the patients actually end up taking that medication. The way that I see it, and I reflect on Oregon data, Oregon is probably the first state that developed assisted, they call it assisted suicide, we call it medical aid in dying. When they interview families after something happened, actually the reason in general is because patients are afraid of symptoms not being controlled. So the more hospice is there and we're able to control symptoms and palliative care and able to control symptoms, there is less need for patients to take these medications because they're suffering on that end. So again, only 30% of the patients end up taking the medication. We also, the other piece that we see sometimes is sometimes patients ask questions about MAID and it's a little bit too late. So some patients actually die before they can have that second visit 15 days afterwards. That's the law, one visit, 15 days later, the next visit. So if anyone, is pursuing or discussing this, it's better to try to do it earlier. And the fact that you have the medication doesn't mean that you need to take the medication. That medication is not covered by insurance, by the way. It's approximately $1,000. That's how much it costs. And we usually recommend hospice to be home. Hospice would not give the medication to the patient, but they are there to provide support. When it comes to death certificates, the law protects the patients. It doesn't read as a suicide in the death certificate, and it doesn't disqualify from any kind of life insurance, etc. So that's kind of like in brief. It's a big law, but if anyone has any other questions, I don't think we brought brochures for MAID. You did? There's some brochures about, it's called Medical Aid in Dying MAID. So Jess brought some brochures. If anyone wants to read a little bit more of that, we have a brochure there from Atlantic.
And thank you for the question about bereavement. So the bereavement support that we offer and that hospice, other hospice agencies offer, there is no charge. If you go like to an outside group, there could be, a nominal fee, but with our program, there is no charge. It essentially comprises most phone calls and mailings at this time. There is also the annual memorial service that myself and Jessamyn just assisted with at Overlook Medical Center. I would say much of it too, in terms of support groups, we're starting to build up our ability to do that. Jessamyn is running a group coming up in February for adult children who have lost a parent. I would say, and two, I often will refer patients to support groups, whether it's one through Atlantic Health and our caregiver center, or if there is another one locally. There have also, as a result of the pandemic, there are many more virtual options as well. But that's primarily what the program looks like, and we do follow for 13 months. And at that time, someone could always reach out to us following that, though, and I would be glad to speak with them and provide resources. Thank you.
Yeah, thanks. That was a very informative presentation. One question that I think I have is the POLST. Once you sign that, that doesn't commit you to do what's there, is my recollection, is that, the time comes when the doctor says, so do you want the ventilator or not? You can change your mind. And so I did have a second quick question, which you can answer at the same time, I think. On the medical aid in dying, do you inform the people of that option, or do you wait for them to know about it some other way?
So you have great questions, by the way. So the POLST, so the POLST, and that stands for Provider Orders for Life-Sustaining Treatment. So the POLST is an order. That's why it needs to be signed by a provider with a license. So it needs to be signed either by a doctor, nurse practitioner, or a physician assistant. So it needs to be a licensed provider. That's the one piece, and it's an order. So the POLST is the one form that is valid in all settings. If you have a POLST, they need to honor it in a post-acute care facility, in a nursing home, in a rehab, in the hospital, wherever you go, the POLST is valid at home. Okay, and it's an order. So there's really no, when you come with the POLST, they should follow those orders that are in the POLST. Can you change the POLST? Yes, we have patients that change their POLST all the time. There is an element, and Jess was showing the form there. There is also a square there in the POLST that you may or may not give the permission to your surrogate to change things from there. So there's a specific line in the POLST that says, if I lose my capacity of making decisions, can my surrogate change what is written there? So you can say yes, or you can say no. And I can tell you it's a 50-50. I have a lot of patients that tell me, no, I don't want anyone to change this because I know my daughter is going to come and she's going to try to put me in a ventilator because she wants me to be longer in this world, which I don't want that. So you can select that. But it's an order, and it's an order that needs to be respected in all the settings. Yes, you can update it. We recently implemented in Atlantic an electronic pulse also that stays in the system. It would probably be ideal to have that electronic form really shared throughout New Jersey, that's not there yet, but that's there. So that's about the pulse component. But it's the best form. Jessamyn was talking about that because when we read living wills, there's so many gray zones in living wills, and it's usually written by a lawyer, or it's a template that is already there. So it has a lot of elements like, okay, if I'm in this situation, I want 20 doctors to say that this is end of life. And sometimes there's so many gray zones that when families are trying to understand what their loved one wants, that sense, it's hard even for them to say, yes, but he said this, he said that. There's a lot of gray zones. The pulse is pretty straightforward. And if you see about the pulse is not a form that it's only for don't do this. No, if you want resuscitation, you document in the pulse. I want resuscitation. Do you want a feeding tube? It's documented in the pulse. You don't want it, it's documented in the pulse. So it's not like you're taking away or you're putting everything on. It's just your wish is really reflected in the form. What was the second question? About made? Okay, how we provide the information. So this is very interesting, and this has been a conversation that we've had. I do have the conversation with a lot of my patients in the clinic. especially in the clinic. In the hospital, also patients bring it up. I think when we do assessments and we have the feeling that that's kind of like the goals of the patients, we bring it up. Do we bring it up 100% of the times? No. No, to be honest, we don't do it 100% of the times. I think we spend so many times with patients and families that we have that sense, okay, this is probably a patient that would want this information. So patients just come with I want this. And I want this in the hospital. By the way, MAID cannot be done in a hospital. All right. So I think from facilities like Center for Hope, they're comfortable, but there's some long-term care facilities that are not comfortable with patients doing MAID in their facility. So those are things that we're navigating over time with the program. But that's a great question. I thought you were going to ask. I have a friend in the West. I thought you were going to ask. I have a friend in the West Coast that wants medical aid in dying. By the way, for medical aid in dying, you need to be a resident of New Jersey and show proof of residency in New Jersey.
Yeah, I'll
So
get to him in a moment.
So we end up checking, driver license, et cetera, just to make sure that they're resident, because it happens, this law does not exist in New York. This law does not exist in Pennsylvania. So these neighboring, states, sometimes patients feel like they can come in and ask for medical aid in dying. New York is working on that. Actually, our team from Atlantic went there for a presentation at the state level, but it's not approved yet.
Okay, good. I have a friend on the West Coast whose wife has incurable cancer. She's in about 6 months of treatment. And he's struggling. He's trying to figure out what to do. And I think a lot of the questions have to do with palliative care. And that's the reason why I wanted the presentation. So the question is, how do you get the person across the bridge between treatment and comfort care or palliative care?
So this is what we do every day. So, over time, we become almost like oncologists because we need to know a lot of the treatments that may be offered. When it comes to a situation like the one that you're describing, we try to balance all the components. And again, it's trying to gather all the information. What are the potential treatments? What are the risks and benefits? When it comes to cancer treatments, which is specifically what you're talking about, I think there's 2 or 3 elements that we always try to address. Number one, how is that person functioning? It sounds like a simple question. We always ask, how are they walking? Do they need a walker? Are they in a wheelchair? Are they spending too much time in bed? What's even the structure of where they live? Because if there's going to be some transition into hospice at some point of time, is there too many stairs? Is there a bathroom on the first floor? How are we going to accommodate all of that? The other component is the nutritional component. So it's really balancing the risk and benefits of treatments to try to help that person make decisions. I also want just to mention something like palliative care is not there to try to convince everyone not to get treatment. No, it's not like that. All right. So I can tell you in many years of career, and I've been practicing palliative care together with hospital medicine for many years, but I have patients that I was the one who convinced them to get more treatment because they were functioning well, nutritionally they were doing well, they were a little scared. I tried to figure out what's this care process. And the other piece is that even if you start a treatment, for example, a cancer treatment, that doesn't mean that you need to finish it. If you're not feeling well, if you're having too many side effects and you're balancing all of that, you can always stop it. So, and there's really, there's a whole spectrum, I have patients, and we see a lot of patients from Memorial Sloan in the hospital. And I have patients that they want to go all the way. They want all the potential standard treatments. They want to go through trials, etc. So, but I think a lot of the conversation has to do how they're functioning, how they're doing nutritionally, and try to balance the risk and the benefits. Because if we feel that the risk is more than the benefit, sometimes less is more. And there are studies out there of patients that actually, there's a study from Boston, and they actually look at patients with advanced lung cancer and patients that actually selected more of a palliative approach rather than an aggressive when they were advanced. And that study, actually, patients live longer in the arm with no treatment. So a lot of times, treatment is not the best option. We are not there to make the decision for patients, but we're there for patients to make an informed decision, and it can go in any direction. So, but I think it's important always to think about their functional status and their nutritional status as a baseline, and then balance the risk and benefits of intervention.
We're getting great information, but we are running very late. So Bob, please, a short question.
I just have a point of information on bereavement. I don't know if, I'm sure you people are aware of it, but Imagine, the group Imagine Mountainside, they're a nonprofit organization. They were started in 2012, and they run a terrific bereavement program. Children who've lost siblings, their parents, your parents, your brothers, your sisters. So if anybody wants information about it, just go online. It's called Imagine, and it's really a wonderful program. Second question I had, with respect to the living wills and all that, do you do consultation? Like if somebody wanted to go over what, their living will and or other aspects of the process, and they're not end of life situations, is somebody come in and talk to you about it?
The way to think about it is if it has anything to do with financial, that would be out of our scope of practice. If we are talking about an advance directive or getting more information about the complexities of making decisions about end of life, of course, we're here to talk to you about that. But I think, really looking at it within the context of of where you're at in a disease process or where you're at in terms of your age, palliative is always available. That's what I love so much about this discipline. But we are not so accessible in the outpatient setting unless you have cancer, or unless, we're something to be utilized very much inpatient, especially at Overlook. We do have ways to work with families and patients out of the hospital, but I would always look to your financial advisors, and I would look to any of the elder law attorneys that are going to probably have a social worker embedded and be able to talk to you about those end of life goals. And I did want to mention another thing. I think is very important to remember that when you have a loved one, your friend in California with the wife who has cancer, or your cousin, or your Uncle Fred who is really struggling, it is ask for a palliative consult, or encourage your friends and families to ask for a palliative consult when they're inpatient. That's something that they can request themselves. It's not something that has to be sort of, unleashed upon them by the medical system. This is a resource for patients and families who are struggling and who want more information. That is something that you can request or tell people to request for themselves.
Just one last thing about that. So we do understand that there is a gap when it comes to discussing goals of care and advanced care planning. It should really start from primary care providers. Yes. We're working, and I just want to mention that we're working with a corporation in trying to enhance these conversations, having certain triggers for certain diagnoses, certain age, certain components in which we need to trigger providers to have that conversation, and have some other, social work or transitional care nurses are starting those conversations with patients and families. So we're structuring that. We know that there's a lot of opportunity to improve on that end, but we're always available if there's any questions, from the palliative care perspective.
Terry, it's up to you.
Okay, so if I can have you back up for just a moment, I'm going to give you a certificate of appreciation. I would take it as a sincere appreciation for the talk that there were so many questions. So I have these three. I'll let you start them out. The cover of that is the orchid, which is the symbol that the Seminole Guard adopted back in 1930 when it was formed. And at that time, Summit was a center of orchid production and distribution. So I also have for our lovely speakers, I have orchids, real orchids. We're not always graced by women speakers, so thank you for coming and appreciate the audience allowing you to go a little bit later because they had a lot of questions. Thank you.